This is one in a series. I think we have 4 this year of co-sponsored grand rounds with biomedical engineering. And Dr. Bob Kirsch, who is the chair of BME, is here with us this morning. We have several people here from the School of Engineering and also from neuroscience. And as I think many of you know, we've been increasingly cooperating with the School of Engineering and our neural engineering program. And I think as one example of that today, we have Martha Morell, who is currently the Chief Medical Officer with NeuroPace, but Martha is going to give us grand rounds today. But to do the introductions, we have someone, I'm not sure how many of you know Dr. Cameron McIntyre. Oh, who's going to, is Bob going to do it? Come on, you got the gift? Come on. So Dr. Cameron McIntyre from the School of Engineering is also going to do the introduction. Cameron?
Great. Thanks. So Dr. Morell is a very interesting clinician scientist in that she is pushing the kinds of neurotechnology that we in the School of Engineering at Case and a long list of people have been really saying, wow, pontificating that we need closed-loop neuromodulation devices, and Dr. Morell is actually, making this happen. So it's very exciting new technology. She did her medical degree at Stanford, then residency in neurology at Penn, and then really got her clinical career going, starting an epilepsy center at Columbia, and then came back to the Stanford and Palo Alto area. And now is made the transition out of sort of full-time academia and into more of this translational or industrial role. So I'm very excited to hear about the latest with the NeuroPace technology, and like to introduce Dr. Morell.
Thank you, Cameron. Thank you. Thank you. I do want to correct one part of Cameron's very kind introduction. And I didn't start the Epilepsy Center at Columbia. I carried on from Dr. Luters, who preceded me there. I'd started at Stanford and then went to Columbia to carry on the extraordinary epilepsy tradition that he was pretty instrumental in establishing. It's very exciting to be here. I have made a transition, as Cameron said, from full-time academics for 18 years in academics to this hybrid role. And so now I work with a lot of engineers. I recently married one, and I have 2 stepsons who are engineers, so my whole life is engineers right now. I have found it so incredibly exhilarating to move into a world where there are people with such different backgrounds and such different knowledge sets who are coming together to work on really entirely new treatment paradigm. And although I'm going to talk about epilepsy today, this is relevant to brain disease. And I would say that immediately relevant to brain diseases such as depression, which is a brain disease, and to pain. And actually, I'll just kind of jump in and talk about some of the broader applications. We know that there is one brain stimulation device that's been in use for a long time, electroconvulsive shock therapy, and that really is the most effective treatment for depression. But I think what many of us are excited now is applying brain stimulation to regions that have now been identified as foci for depression, for bipolar disorder, maybe obsessive compulsive disorder, and maybe substance abuse. And these trials are undergoing, and I'm absolutely convinced that it works. There, of course, is a long history of using brain stimulation for treating movement disorders, and this is approved. But there's a great deal of innovation going on in this field, too, including looking at systems that might be able to treat movement disorders using a closed-loop approach, as I'm going to tell you about in a moment. Motor cortex stimulation is not approved, but is still widely used for the treatment of pain and is very effective. And what I'm going to focus on today is epilepsy, because that's what I've been doing and that's what I know. We have a mixed audience here, so I want to provide some context. People may not recognize that seizures are really quite common. 1 out of 10 people will have a seizure in their lifetime. That doesn't mean that one has epilepsy. Epilepsy, by definition, is a neurological condition where there has been more than one unprovoked seizure, so recurrent unprovoked seizures. But here's one problem with this, is that we're simply describing phenomenology and not describing the underlying disease. And so epilepsy, like many chronic disorders of the brain, is a collection of diseases that share a symptom. In adults, the majority of epilepsies are partial onset. They're not genetic. They're occurring because there is a focal area of dysfunction capable of generating seizure discharges. Just because we call it partial doesn't mean the seizures aren't bad. These individuals frequently have seizures where they have loss of awareness, and the seizures may then go on to generalize and cause generalized tonic-clonic or convulsive seizures. So this can be very disabling. We have a number of medications to treat epilepsy, and fortunately, most people can have their seizures controlled, but it's not a large majority. About 30% of people do not have their seizures controlled, no matter which of the medications that we use. But the flip side of this, and one that I think that probably of necessity we haven't listened to our patients enough about, is their concerns about the side effects of the medications. We haven't listened to it because we haven't had alternatives. But an equal number of people, 30 to 40%, have side effects, usually cognitive, fatigue, coordination problems, that really limit their quality of life. And anybody who's treated patients with epilepsy knows that there are a number of patients who say, you know, I'd rather not take the medication, I'd rather have the seizures because of these side effects. People who have these seizures, this is a progressive disease. It's progressive socially and biologically. There's a lot of stigma surrounding epilepsy. There are clearly limitations in educational and occupational achievements. But having these repeated seizures is not good for the brain either. And over time, individuals with medically intractable partial seizures, many of them have diminishing cognition, particularly in the area of memory. So it is socially disabling, and it is also progressive. So there has been interest in how we could treat epilepsy using devices, getting away from drugs or supplementing drugs, really. And many of you are familiar with the vagus nerve stimulator. And this is an approved treatment for epilepsy. It's widely used across the world. The system stimulates the ascending vagus nerve on the left. There is a pectorally implanted pulse generator that's connected to a lead that's tunneled subdermally and then wrapped around the vagus nerve, which is adjacent to the carotid. We don't know why it works, but we don't know why many neurologic therapies work. They often come to light because of empiric observations. But it is definitely a very welcome addition to treatment options, but it's not, excuse me, it's not perfect. Some of the same individuals that were involved in the early vagus nerve trials went on to look at trigeminal nerve stimulation. And this is typically stimulation of the first branch of the trigeminal nerve, V1, which innervates sensation to the forehead, but also has a lot of input into the brain, similar to the vagus nerve stimulator. And the first device is an external stimulator. The patients wear 2 electrodes on their forehead. The stimulator is worn kind of like my little microphone thing, and they're stimulated at night. And the results appear fairly promising in a small number of patients, 50 patients, that there is somewhere around a reduction in the high 20s, but this is a non-significant risk device. They believe also that by using an external device, you could predict people who would respond to an internally implanted trigeminal nerve stimulator. And of course, it would be nice to be able to identify in advance those people who would benefit from an implanted device. But the focus that I've had, and that my colleague Bob Fisher at Stanford also has had, is looking at deep brain stimulation. And there are two investigational products. These are not available in the United States. Examining different ways of approaching the problem of medically intractable epilepsy. And the first is deep brain stimulation, using the same technology that is used for treatment of movement disorders, but using a different target, the anterior nucleus of the thalamus, a fixed anatomic target. And then the other approach, which is what I've been working on, is responsive stimulation. Responsive stimulation delivered specifically to the seizure focus, so a non-fixed anatomic target. I mentioned the vagus nerve stimulator. It has been approved by FDA as adjunctive therapy for epilepsy for quite some time now. It is programmed. There's a duty cycle. The duty cycle is typically around 20% on versus off. And in the randomized controlled trials, there was a 25% reduction in seizures during the blinded periods. Now, I emphasize that because one of the issues here with the new therapies coming out is that you will be seeing results from the blinded periods of randomized controlled trials. You will hear in the neurology community that 50% of people with a VNS have a substantial reduction. And that is probably true in the broader population. Once any treatment is released to a population that's less ill, it tends to work better. But it's also open, so there's the investigator and patient desire to do well. So as you look at these devices emerge, please be sure that when you think about how they compare one to the other, that you are comparing similar times of assessment. So this will be our comparator, is 25% improvement. I mentioned two approaches. The first, the DBS approach, which is scheduled stimulation. It typically is not delivered continuously. It's scheduled. In the epilepsy trials, the stimulation was being delivered about 20% of the time. But it is a device that you set it and you forget it. And there's a lot to be said for that approach. It's easy, it's accessible to the physician. The other approach is to do closed loop, and that is to deliver stimulation only in response to an event. Now, this approach is very attractive for epilepsy because epilepsy with seizures is characterized by a number of discrete events, and most patients spend most of their time not seizing. And so treating the patient only when it's needed theoretically was a very attractive option, but I will show you that our thoughts have evolved. We thought we were going to provide responsive stimulation to stop seizures, and what we recognize now is that we're providing a neuromodulation therapy. And I'll explain what I mean as we go on. There is a long history dating back from the 40s of trying stimulation for seizures, and I've just listed some of the targets. Most of these trials were positive, but they were studies in very small numbers of persons, typically not well controlled, not necessarily reproducible, and not carried on to do the types of large-scale definitive trials that have been done now with deep brain stimulation and with responsive stimulation. Except for the last one, the anterior nucleus of the thalamus. And this is the target that was chosen for the deep brain stimulation trial. The device that was used in this trial is a commercially available device by Medtronic, a pulse generator implanted in the pectoral area and then connected to DBS leads that were placed bilaterally in the anterior nucleus of the thalamus using standard stereotactic techniques. This is approved in the United States and Europe for treatment of Parkinson's disease or essential tremor with the target there being the subthalamic nucleus or globus pallidus. But the anterior nucleus for epilepsy has been approved in Europe for persons with partial onset seizures. It is still being considered by FDA. The SANTE trial, which is the trial completed, oh gosh, 4 years ago, I guess, was a multi-center, double-blind, randomized trial. It was performed at 11 implanting centers in the United States. These were patients who were very ill with epilepsy. They were required to have 6 or more seizures per month and to have failed a number of anti-epileptic medications. They were randomized 1-to-1 to receive active stimulation or sham stimulation. So all patients were implanted with the device. Ultimately, there were 105 patients who were implanted. And just to provide some context, these were the sickest of the sick. Over 2 decades with epilepsy, a median nearly 20 seizures per month. And these patients had not only failed anti-epileptic drugs, but many had tried epilepsy surgery, and it didn't work. Those who had not had epilepsy surgery were almost all had been found not to be candidates for epilepsy surgery. And close to half had had the vagus nerve stimulator, and that hadn't worked. So the way the study worked is there was a baseline, and then the device was implanted. Let me see if this works here. So the device was implanted here, and then something happened, which everybody in epilepsy knew would happen, and that's called the implant effect. So when we do a neurosurgical procedure on a person with epilepsy, their seizures get better. And we know that from doing intracranial evaluations for epilepsy surgery when electrodes are implanted to see where the seizure focus is coming from. And you know, you always know that your patient's going to get their best seizure control or may get their best seizure control for a couple of weeks, so we reduce their medications. But what they found in the Medtronic trials, just from the implant procedure, there was a reduction in seizures of about 20%. And so I'm going to tell you why this is an issue for trial designs for devices, at least for epilepsy. But what happened then is the group that was not receiving stimulation, which is in the red here, they didn't get better from that point on, and then actually they started to drift back up again, although in this period of time, which was 4 months after implantation, they hadn't gotten back to their baseline. But clearly there was that trend. And what you see in the treatment group is that there was a continued reduction with stimulation. And the good news about this for epilepsy is that in contrast to anti-epileptic drugs, which often wear off, not always, but you know, we all have these patients who, no matter what we put them on, they do well for about 6 months, and then it stops working. So in contrast to the medications, down here is good. This is actually this histogram represents data on each individual patient. And so you'll see that this is at 1 year, which I neglected to put on the slide, but at 1 year, the median percent reduction was 56%. And there's a range, of course, because these are all different diseases. So we really need to know who these people were, and then we need to know who these people were. What diseases do they have? But anyways, a very durable effect. This was very well tolerated. The most common device-related adverse events were paresthesias, which could be addressed by changing the stimulation parameters, and pain at the implant site temporarily. They had actually extremely good neurosurgeons because they got it in the anterior nucleus of the thalamus 92% of the time. And the hemorrhages they had were all incidental. They were picked up by MRI, and so they weren't symptomatic and all resolved. The issue, of course, with implanted medical devices, which is new to neurologists, is having infections. Neurologists, we haven't really used devices before, and so neurologists are very concerned about this. And the infection rate was not bad. It's comparable to devices used for movement disorders and other implanted devices, but most of the infections are at the pectoral site of the pulse generator or in the lead extension tract. What happens is the infection starts here and then it tracks up. But most of the patients could be treated through, or those who could not, who were explanted, many of them chose to be reimplanted because they were pleased with the device. So let me move on to responsive stimulation. There is a long history of applying stimulation directly to the brain to interrupt seizures. And this started with Penfield and Jasper during routine procedures to map brain function in the operating room. And these were typically mapping brain function prior to epilepsy surgery to define a safe resection area. And as part of that brain mapping, you apply electrical stimulation focally, and sometimes you get seizures. And we all have had this experience with brain mapping, and we all know that if you then just deliver stimulation again, sometimes you could stop the seizure and then go on with your mapping. But they were the first to make this observation, and then Ron Lesser, an epileptologist at Hopkins, looked at this more systematically and reported that by applying brief bursts of stimulation, you could induce after discharges, which let's just call those electrical seizures, and then you could apply a secondary stimulus that would stop it, and so this kind of reinforced the earlier experience of Penfield and Jasper. And then Ivan Osorio and Peter used an external setup computer and used patients who were already implanted with electrodes to be evaluated for epilepsy surgery, and looked at spontaneous seizures, applying stimulation in response, and reported they were able to block it in 8 patients. Well, 14 years ago, we started to think about a device that could provide closed-loop stimulation. And this is how this happens. I was at Stanford running the Epilepsy Center, and they were moving my boxes out because I was moving to Columbia, and a man, Frank Fisher, who's now the CEO of NeuroPace, wandered in my office and said, we have this IP from an inventor, Robert Fischel, whom many of you know, and Kleiner Perkins, a venture capital firm, is willing to throw $1 million in because they believe in Bob just to see if something like this would work. Do you think that you could stop seizures with stimulation? And I had just come from a patient that I'd been mapping where I'd done that so that we could go on with the mapping. So I said, yeah, no, I think this concept is very interesting, but you're going to cause seizures, so that it's not going to be safe. And number 2, the detection software there are people who spent their lives working on detecting seizures, and this problem hasn't been solved, and you're not going to be able to solve this. And he said, well, let me take it back to the engineers. So I did some proof of concept stuff at Columbia, and we did some closed loop with external devices and became convinced there might be something there. And then, of course, they had to make the device. This didn't exist. So had to raise $45 million and get together some pretty unbelievable engineers, many of whom had been involved in creating or developing the first implantable cardiac defibrillator. And they said to me, this is really the same problem, it's just a little more complicated. And so after 4 years, what became available that we could actually then see if it worked was the RNS system. And the RNS system has implantable and non-implantable components. The decision was to go with a cranial implant. And the reason for the cranial implant was if you're going to do a responsive system, you need the best signal-to-noise ratio that you can get. And so you want to be really close to where you are recording from. And then also the thought was that we could reduce the infection rate if we could get away from the pectoral implant. We could also reduce the risk for lead breakage, which is an issue with the devices that are implanted pectorally. And then I, as an epileptologist for 20 years, said, I would really like a device that's invisible, that the patients can't see, so they can forget that they have seizures and they don't have to go around with something that's bulging that's a constant reminder. And so went ahead with a cranial implant and used a lot of what had been learned from the cochlear implant to design this. The cranial implanted neurostimulator is connected to up to 2 leads. Those leads can take the form of a depth lead, which you see right here, or a subdural strip lead. Each lead contains 4 electrodes, and then the can be used as a reference. So there are basically 9 points of reference and 8 for stimulation. The physician decides whether leads or depths or a combination of the two are implanted depending on the seizure focus. The neurostimulator has 2 custom integrated circuits, the battery and a connector assembly. But these integrated circuits are able to continuously sense the electrocorticogram and to detect abnormal electrographic activity. So what's abnormal electrographic activity? It's whatever the epileptologist says they want to detect. And there are detection algorithms within the neurostimulator that can be programmed to detect essentially anything that the neurologist, it's typically the neurologist, sometimes neurosurgeon, wants to pick up. And then when an event is detected, stimulation pulses are delivered through any or all of the electrodes. And the stimulation is also selected by the physician, and there are a lot of options, maybe too many options, because there are a lot of variables that we're dealing with here. But here's an illustration of this is a recording from a patient. And here there are 4 channels that are recording, in this case bipolar. What we are seeing here is that a discharge is developing, which I think anybody would call epileptiform at this point. The device has been programmed to detect fast frequency, high amplitude activity. Here is the detection. And here is the stimulation. The device then redetects, and if it detects something ongoing, will deliver another stimulation. In this case, has looked at it and said there's no redetection. And this can go on up to 5 sequential stimulations, and each stimulation has 2 bursts, and every burst can deliver a different kind of stimulation. So here, again, I'm saying we've got a lot of variables, which is good, but it's also a little bit of a problem in terms of how we analyze all this data. But these are the type of typical electrographic patterns that a physician might say should be detected. And one is a spike pattern. The other is rhythmic theta frequencies. Here's all examples in blue where there is a detection and then following stimulation. Here, beta, which is very classical for seizures rising from the neocortex. And then what we see a lot now that we're on the brain, which we couldn't see from the scalp because of the filtering from the meninges and the skull and the scalp, we see these very fast activities, this gamma activity. And in this case, electrodecremental pattern, which is even faster activity. So there's the neurostimulator in the leads, and then there's a programmer, of course. The physician communicates with the neurostimulator using a wand. The physician pulls off information from the neurostimulator, including device information like battery and impedance. And then also a history of all of the stimulations and detections that have been made, time and date stamped, and as well as recordings of electrocorticograms that the device has been instructed to store. The physician then can program detection and stimulation settings specific to each patient. And in our trial, the physicians were able to change detection and stimulation throughout the trial because we didn't know where the optimal settings should be. And now I know that there are no optimal settings. It depends on the individual patient. But then something that's really pretty interesting and powerful about the system is all of this neurostimulator data can then be transferred from the physician programmer to a web-based database, which is secure. The servers sit at NeuroPace. And all of the information on the device and on detections and stimulations, programming, it's stored there forever, including the electrocorticograms. And then what the patients love and what is additionally powerful is they take home a remote monitor, which currently is a laptop. Hopefully it'll be a little more sophisticated and smaller in the future. But the patient can then retrieve data from the neurostimulator and transmit that over a phone line or any kind of computer portal to the patient data management system. So the physician can look at all this data offline And the patient the first time the patient has been able to communicate objective information to the physician about what's going on with their epilepsy. So on this patient data management system, there's a whole lot of information here, but this is an example of one, these stored electrocorticograms. And there are also quantitative analyses that are available on these. And here we see a seizure developing and then a detection. And I love the frequency spectrums myself better than the condensed EEG. And here what we see, and I know this is pathologic, but at the same time it's very beautiful. What we typically see in seizures is that from this kind of desynchronized broad spectrum of frequencies that characterize the non-pathologic state, that as a seizure occurs, there is this segregation into these very tight frequency bands, and they tend, you may have more than one frequency, but they're multiples of each other. So you may see it at 10 hertz, 20 hertz, 40 hertz, but it's not random. And so I look at these and I say, wow, I know exactly what I want to detect. I'm not really going to pay that much attention to the ECOG. I'm going to program this device to detect a change in the spectral frequency in the 40 hertz range and to detect and treat there. So this is really powerful. We also get a lot of information clinically that's helpful to understand what's going on with our patients. So this is a histogram, and what this represents is all of the detections and stimulations that have been delivered to this patient, and this is by day. So you can look at cycles over a month, and in this case, you can't see this x-axis. In this case, this patient, if you look month by month, always shows this type of a cycle. Now, this isn't necessarily clinical seizures, but this is abnormal electrographic activity that's being detected. This is a woman, and this is the premenstrual period. So this is a woman who has catamenial or menstrual-associated seizures, which are pretty common. And I would look at this and I'd say, okay, so I know on this day in the cycle, maybe I want to intervene with an additional therapy to give her additional protection during this period of time. And you can also do hour by day to look at circadian cycles, and you can do minute by hour. You can look at the data array in any way you want. So at any rate, we took this technology and we applied it in a feasibility trial, first of all, just to ensure that it was safe and to see if there was some reason to believe it might work. And that was in 65 patients. And based on that, we went into a pivotal trial, randomized double-blind sham stimulation controlled trial, a standard trial design. It was baseline period. Patients had to have an average of 3 or more disabling seizures a month during that period of time. And then they were eligible for the implant. After the implant, we turned detection on in everyone. We gave it 4 weeks, and then people were randomized at this point 1-to-1 to receive stimulation in this arm or to have sham stimulation. We gave ourselves 1 month to optimize the stimulation. In retrospect, that was not enough time. And then at this point, so 2 months after implant, the seizure diaries that the patients had been keeping the whole time, that information was used towards the primary effectiveness endpoint. And the endpoint was to show that there was a statistically significant reduction in seizures in the treatment group compared to the sham group. At 20 weeks, or 5 months post-implant, everybody got stimulation, but nobody has ever been told, actually, to which arm they had earlier been assigned. In order to maintain the blind, we had one team that was the assessment team, and they were responsible for gathering all the data for efficacy, all the seizure count data, the quality of life data, and they had nothing to do with the device. And then we had a treatment team, and they managed the device, but they did not gather any of the data on effectiveness. So, and we were able to successfully keep the blind because people don't know when they're being stimulated. They don't feel it. We also had very ill patients, similar to the Medtronic experience, also 20 years of epilepsy, 3 anti-epileptic drugs taken at the time they were participating in the trial. They'd been on many more historically. Median number of seizures of 9.7. A third had had the vagus nerve stimulator. It hadn't worked. 2/3 had been evaluated for epilepsy surgery with intracranial electrodes, and a third had already had an epilepsy surgery. The vast majority had had a resection of an area of the brain. And here's the data in the blinded evaluation period. So what we found is that there was a reduction in seizures with the implant that Medtronic saw. We did our studies concurrently, so we didn't learn from them and they didn't learn from us. But you'll see in the first month, there was a reduction in seizures of 34% in the treatment group. There was a reduction of 25% in the sham group. So we were not able to show a difference in that first month. But in the second and third months, you see a continued reduction in the treatment group, whereas the sham group has almost returned to their baseline by the third month. And overall, for the entire blinded evaluation period, you get this number, 38% in the treatment group and 17.3% in the sham, and this was highly statistically significant. In retrospect, though, we could have waited another month or another 2 months before we started the seizure count towards the effectiveness or efficacy analysis, but you learn as you go on. And we all know now that we can't design device trials like we design drug trials. Similar to the DBS, this is a durable therapy. In other words, if somebody responds to stimulation therapy, it doesn't go away. And not only do they continue to respond, but it gets better. And this is different than drugs. So I would say that you see continued improvement in the majority of patients over that first year, and in many patients, even up to 2 years, after which there appears to be some stabilization. So you'll see that whether we look at responder rate, which is the percentage of patients that have a 50% greater reduction in seizures, or we look at median percent reduction in seizures, that we have this trend upwards. And this is significant. In the first 2 years, this is a significant upward slope. What about tolerability of stimulation? Well, one thing we were concerned about is, well, are we going to hurt people's brain function by stimulating or disrupt it, particularly since we're often stimulating in the hippocampus of the temporal lobe, an area that's very important to memory. But in fact, there was not only no deterioration in any of an exhaustive battery of neuropsychological testing, but we found improvements in visual, spatial, and verbal function, and also in memory. And that was somewhat of a surprise. And I think in fact, it's not necessarily a surprise to me anymore, because if we can reduce the numbers of discharges, then we can allow the rest of the brain to function better. And we also saw what is probably the most important endpoint, which are improvements in quality of life, using a validated, widely used inventory for epilepsy. Now, you see this with drugs also. You see, if a drug works, you see improvements in quality of life at 1 and 2 years. But you do not see it in the domains that we saw, subdomains that we did see improvement in as well. So not only were they generally happy in their life, happier because you see that with drugs, but we saw improvements in cognition, attention, concentration, memory, and language domains. And these are areas that are often negatively impacted by drugs. But of course, we're concerned this is an implanted medical device, so what about safety? And so for the safety, we pooled our experience with patients in the feasibility and the pivotal trial, and that gave us 256 patients. We're currently at over 1,200 patient years of experience, but what I'm showing you is the data that has been submitted to FDA. The official data is up to 903 implant years. And during the blinded period, there was absolutely no difference between the treated group and the sham group in the overall rate of adverse events or in any specific adverse event. No difference at all. And then during the open label period, we did not see an increase in the rate of subjects experiencing an adverse event or the numbers of events experienced over time. And there were no serious unanticipated device-related adverse events. So that's great, but what is our special concern with an implanted medical device? Well, it's hemorrhage and infection. Fortunately, we were able to find that the rates of hemorrhage and infection are at least comparable to what has been experienced with deep brain stimulation for movement disorders. We had 2.3% of the patients had a hemorrhage in the first 28 days, but the majority of these are the trivial asymptomatic hemorrhages that occur anytime a neurosurgical procedure is completed. Nobody had any neurologic symptoms from it. They resolved without intervention. And then over the 903 implant years, 4.6% of patients had a hemorrhage, but the majority of these were because they had seizures and fell and had head trauma. The majority were not considered to be device-related. And as you can see, I think it was only one patient had a hemorrhage that led to explant of the system. Implant or incision site infection. I think it's fair to say that our experience with a cranial implant has been good as far as the infection rate. And in fact, the infection rate is lower if you look at event rate per year. We have more follow-up data than the Medtronic, the SANTE trial has presented. So this is over 903 years, but the event rate for infection is about half that has been reported for the deep brain stimulation devices, and that makes sense because if you eliminated the infections at the pectoral implant site, that's half of them. And as you can see, most patients, 4% of patients over this entire experience did have the neurostimulator explanted, but many patients could be treated through. And of those who had it explanted, essentially all of them are waiting to have it reimplanted. So what can we say about these two trials? The two trials of direct brain stimulation for epilepsy. I think we can say that there are two trials that looked at patients with the most severe epilepsy and showed that there was a reduction in seizures. And both trials showed, I believe quite convincingly, that the effect emerges over time. So that raises interesting questions about what the mechanism of action is. That suggests this is not just an effect on axons or on synaptic events. This suggests to me that there are effects on networks and that there's some type of beneficial remodeling that occurs over time. We also can say that there were no surprises as far as the safety experience was concerned. In either trial, the risks were either similar or maybe were certainly no worse than other implanted medical devices. And we can say from both trials that the patients tolerated this very well. It doesn't have the drug-like side effects. They didn't go ouch every time stimulation was delivered. And there were no negative effects on cognition or on mood. But there are a lot of questions that need to be answered and ones that we're trying to kind of systematically pick off. And the first is, does the brain electrode interface remain stable over years? Because you noticed that the median age of our patients in our trial was 30. So most of these people are not going to die of their epilepsy. So we're looking at a therapy that needs to remain effective over hopefully 40 years. And obviously there hasn't been that kind of experience with these devices. In Parkinson's disease, these are older people. It only needs to work for about 10, maybe 15. And then the other question is, there a place where should we be stimulating? And is there an optimal target? And then how should we stimulate? Medtronic in the SANTE trial used the same settings that are used for deep brain stimulation for movement disorders just because there was experience there. And we were all over the place, as I'm going to show you. So we have to answer that question. And then we have to say, people ask me, well, why not just do set it and forget it? Why use responsive stimulation? And I can't necessarily tell you that responsive stimulation is better as far as the efficacy. You cannot compare the two trials because the patient populations were different. But I think that's a question we have to ask. Well, we have been looking at the brain electrode interface, and this is work from one of our neuroscientists at NeuroPace, Brett Wingar. And what you see here are impedance changes, and this is an example of one patient who has a depth and a subdural lead out past 1,000 days of implant, including a point where the neurostimulator was replaced. The leads are not replaced, the neurostimulator is replaced. And this suggests that for both depth and subdural electrodes, in this one patient, that impedances remain very stable. Well, what happened with the population? Well, here we have data from 188 subjects with a median follow-up of 802 days for both depth and the subdural leads. And you see there the the actual impedance, the mean impedance, and the confidence intervals. And inspection of this data and statistical analysis of this data indicates that the impedances remain stable over time. The impedances are very tight. The range is tighter for the depth leads, depth electrodes, than they are for the subdural. But this is reassuring that this is something that, at least as far as the electrode-brain interface, will remain stable over time. And what about an optimal target? Well, I will tell you what I believe, and that is there's not going to be an optimal target. This isn't one disease. There are going to be different targets that will be more or less effective depending on what we are treating. It appears that deep brain stimulation is effective at the anterior nucleus of the thalamus, and I know there is interest in looking at other targets, including white matter tracts, and Dr. Duran has been doing for some years now some very exciting work looking at stimulating in models of epilepsy in white matter tracts, including the fornix, and that would make a lot of sense. And with responsive stimulation, half of our patients were implanted in the hippocampus because they had mesial temporal lobe epilepsy, and the other half were implanted on the surface of the brain in the neocortex, everywhere, frontal lobe, occipital, parietal, temporal, everywhere. And we have people who have responded in each of these locations. But I think what actually may be more probably predictive of response is the pathology. And so here's just an example. These are the mesial temporal patients. And what you see on the y-axis is the median % change in seizures. Going down is better. And the first bar is those patients who have scar tissue in the hippocampus or mesial temporal sclerosis. And here are people who have seizures beginning in the hippocampus, but the hippocampus isn't scarred up. And so this is a suggestion that maybe if you have a lot of scar tissue, you don't want to stimulate there. And it kind of makes sense. If you're trying to perturb neuronal populations, why are you stimulating a glial scar? And maybe, so if you have scar tissue, maybe you go outside the scar tissue and you go to a propagation path. But if you have neurons in the hippocampus, maybe you should stimulate right there. So I don't know the answer to this, but it's an intriguing observation. And what about stimulation patterns? Well, we have looked at data from 153 subjects who have been implanted with the RNS system. And you'll see it's pretty evenly divided between those stimulated in the hippocampus, the mesial temporal lobe, and those stimulated in neocortical structures. And I mentioned that we tried different stimulation patterns. So we changed detection. So what we have to do is look at epochs where detection has remained stable, and then look at adjustments of stimulation during that epoch. So that assessment identified 920 programming epochs for which we have electrocorticographic recordings over 3,500 patient months. So this is a very large data set. And I'm now going to show you a bunch of graphs, and what I'm going to tell you that all I want you to take away from this is that we've explored a lot of space, but none of them long enough to tell you what optimal stimulation parameters are. But I've divided them into those patients with hippocampal or mesial temporal onset and those from anywhere else, the neocortical patients, because we think they're very different. And the first observation is good news, that for the majority of patients, and actually let me back up, the patient months are indicated by the gradations in the blue color. So to some extent, that is a statement of our certainty of that observation. So what I can tell you is that we have a fair amount of experience with low amplitude stimulation in patients with mesial temporal lobe epilepsy who have had a very good response, over 70% reduction in seizures. And we have also explored higher current amplitudes. This is only 6 patients. It looks like for the majority of patients, you don't need to go with a higher amplitude. You can get away with a lower amplitude. With the non-mesial patients, we've kind of been everywhere, and I don't think we can make any statement about it. But the good news about this is it suggests that you're not going to drain your battery as fast because you don't have to really give them a lot of juice. And as far as frequency is concerned, we've explored very little space. We started treating the hippocampal patients at 200 hertz. I don't actually even know why. And we have a 55% reduction in seizures in that group. And most of the neocortical patients were treated at 100 hertz. And there's a similar reduction. So what this suggests to me is there's a whole lot of frequency space that we still need to explore, including, and again, Dr. Duran has done a lot of work in here, the low frequency space, where we have almost no experience. The charge density is really, kind of what it comes down to as far as battery life is concerned. And our experience here suggests that, again, we've been all over the place, but it appears that for the majority of patients, we will not need to deliver a high charge density. And again, this is good news as far as battery longevity is concerned, particularly for us with a cranial implant. We don't have the battery capacity that a pectoral implant can have. Now, one question is responsive stimulation any better than continuous? Well, I would actually say that this suggests that you don't need to stimulate all the time. So what this shows is the number of episodes that have been detected and treated with stimulation a day in the mesial temporal group and everybody else. And this is the reduction in seizures. And the suggestion here is that you only need to provide less than 500 distinct stimulation episodes a day to get a really good response. You don't have to go up to 2,500. What does this translate to in terms of total stimulation time? It's less than 5 minutes in total, because most of these stimulations are 100 milliseconds. So to me, this means that you don't have to hit the brain with stimulation all the time in order to get a good response. Did somebody just tell me to stop up there? No. Okay. So what are the advantages of continuous open loop versus responsive closed loop? Well, with continuous stimulation, you don't need to detect an event, so the patient doesn't have to be localized. And sometimes you can't localize a patient, and in that case, our system does not work. If you don't know where the seizure is coming from, you can't apply our technology. So with ours, you need to know where to put the leads, and you need to identify that you actually are in the right place, that you're detecting pathologic events. But what's exciting about it is, you don't want to turn the neurostimulator on and then send the patient home for 3 months and then have them come back and say, I was really terrible these last 3 months. I had a horrible time. I had a lot of seizures. And then say, oh, OK, we better change your stimulation parameters. What we'd really like to do, and this is where we get to neuromodulation, is to identify which events in the electrocorticogram should be treated so that the patient doesn't have the seizures, when you should intervene. So that if you see an increase in these events of concern, you change your therapy, and maybe you start stimulating more, or maybe you change your amplitude, I don't know. But you change it, and then continue to adjust it until you get those seizure proxies, that's what I'm going to call them, down. So that's neuromodulation. You try to achieve an electrographic endpoint without waiting for the patient to have clinical symptoms. And we think we can do that. And so here are 2 seizure proxies that we've discovered are highly predictive of how well the patient is going to do. And one of them are saturation events. So what you see here, I'll just go to the frequency spectrum, is the start of a seizure. And look at this, probably starts here with the segregation, and this is about the 15 hertz. And then you see these bands, and then it goes on. And here in the electrocorticogram, the device has been set to identify events that are of longer than 10 seconds duration, and to identify those as, I was thinking about the next slide, to identify those events that saturate the amplifiers and to count them. At this time, there was a saturation event. And then the other event is a long episode. And so here you see the start of a seizure, and this is going on for some period of time. And the device has been programmed here to identify any episode during which the detection is continuing for longer than 10 seconds as a long episode. And an analysis that was just completed on Tuesday after many days of computers whirring away is that there is a highly statistically significant correlation between the numbers of long episodes somebody has, the number of saturations they have, and how well they're doing as far as seizures. So this is the first time that we thought, well, the physician can now bring the patient in and say how many of these seizure proxies have occurred, even if the patient hasn't had clinical seizures, and say, okay, they're doing well because we've suppressed these episodes, or they're increasing, and so we've got to intervene. So why do we need these new device therapies? Well, for patients who aren't candidates for potentially curative epilepsy surgery, these patients, there's no chance that their quality of life is going to improve or they're going to spontaneously remit. I mean, there are a few outliers, but essentially there's no chance. And as I mentioned, they are going to look forward to decades of deterioration and a higher mortality rate. Dr. Latu's done a lot of work in mortality in individuals with epilepsy, particularly sudden unexplained death in epilepsy. So we know that even if we can't eliminate seizures, which neither the SANTE trial nor we could in the majority of patients, we do have 27 of our patients who have had a 6-month or more period of seizure freedom at this point. But even if we reduce seizures, we can mitigate the risks that I just mentioned. There can be improvements in mood and quality of life. And then also, let's be fair to the devices. The last 15 approved anti-epileptic drugs and the vagus nerve stimulator had median percent reductions of 25 to 40% during the randomized controlled trials. And both our study and the SANTE trial actually did a little better than that, especially if you look in the open label period, much better. So obviously, physicians and patients think that that kind of response is meaningful because these drugs, billions of dollars of these drugs are being sold. And so I would say, from my opinion, that the results from these trials are meaningful to the patients who are suffering from this disease. So I would also say, and I hope there's nobody from FDA here because I could probably get in big trouble, that I think that these trials have shown that the benefits of brain stimulation outweigh the risks for this patient population. And this is certainly a novel approach to treatment for patients who clearly have an unmet medical need. It's estimated there are 600,000 patients in the United States who would fall into this category. And one of the challenges here is that unless FDA approves these devices, nobody's going to get access to them. And what happens then is that there will be no development in this technology and there will be no development in the clinical experience that's going to be necessary to understand how to apply it best. And then finally, and this is a little bit of a preaching, my patients have had a very tough time in their life. And they've made a lot of decisions about treatments. They've been on so many where they've had to weigh the benefits and the risks. And these people are well able to decide for themselves whether the benefits and risks of a treatment make sense for them, and so are their physicians. So ultimately, I believe there's sufficient information from these trials so that patients can decide whether this is something they wish to pursue or not. So areas for future exploration, some of which are being explored here at Case Western, are stimulation strategies. Should we be giving random pulses or fixed pulse? We vary the frequency, but within the frequency that's being delivered, we have fixed biphasic pulses. Maybe that's not the way to do it. Maybe we should be providing adaptive stimulation. Maybe we should be synchronizing our stimulation pulses to the electrographic events, similar to what has to be done in order to defibrillate a fibrillating heart. And then also classes of patients. We really need to understand better how you should treat different onset zones, and particularly how you should treat different pathologies. Sclerosis or scarring probably should be treated differently than areas of cortical malformations. And then, do you deliver responsive stimulation, or maybe you deliver the continuous, which is really fixed and scheduled, or maybe stimulation should be totally random. And there's a Belgian investigator, Paul Boon, who says that he delivers continuous stimulation to the hippocampus, but he does it according to a Poisson distribution. And he says that works a lot better than delivering some type of fixed frequency. And then, of course, the big question is, what's happening here? What are we doing? Because we're doing two things. We have an acute effect, but we also have this funny and I think quite nice chronic effect. And I believe the underlying events in the brain are probably different for those two effects. I think we certainly have effects on axonal-mediated conduction, antidromic and orthodromic. We talked to Dr. McIntyre about it. He's thought a lot about what we're doing axonally. We have effects at the synapse. Dr. Duran has done studies showing that the speed the speed at which epileptiform or epileptic discharge travels through an area suggests that it's too slow just to be axonal. There must be a synaptic variable to it. And then also the chronic effect. Why are we seeing improvements in cognition and mood, but mostly why do people keep getting better and better? And so you've got a lot of people here who are trying to answer these questions, and a lot of people whose brains I was picking yesterday and will continue to do so yesterday. But it's pretty exciting. When I was interviewing for neurology residencies, and I'm sure you can identify with this, well, when I announced I was going into neurology, a number of people in my medical school said, you know, you could do internal medicine, you could do pediatrics. I mean, why would you want to go into anything where you diagnose an adios? So this was the, you know, but my God, look at what's happening in neuroscience right now. We have so many interventions, and I'm looking at the younger people here, and what you have access to and what you do for patients in 10 years from now, I think I probably can't even imagine, and I think about this a lot. So thank you very much for your attention and for the opportunity to spend time here with all of you.
Questions? Do you have any sort of other indicator or measure that might indicate this patient will respond well, like with movement disorders, or you treat them L-DOPA and they respond well, can I receive benefit from DBS?
Yeah, so the question for those of you who couldn't hear it is there some way to predict who is likely to benefit, and what about the patients who didn't get better? So the 12% of the patients in the trial did not have any kind of a response, and 70% had a 30% or greater reduction. So we've tried to look at those patients who didn't respond and, you know, who are they? And the variable they have in common is they weren't well localized. So we really weren't getting clear detections, or the region, the abnormal region, the seizure zone was huge. And they actually were a couple patients who were snuck into the trial who shouldn't have been enrolled because it was too big. So we think we can address some of that by the next generation of device, which will have 4 leads and therefore 16 electrodes. But as far as the externalizing the device, theoretically you could try that out when patients were being evaluated for epilepsy surgery with intracranial electrodes, but you brought up the big problem. This is an effect that evolves over time. So I'm not sure how beneficial that would be. And as far as externalizing a device over any period of time, the only thing you could externalize would be the neurostimulator. The leads have to be where they are. And the infection rate is such an issue there. So then let's talk about, well, what's the problem with going ahead and implanting the neurostimulator? There probably isn't much of one. You're doing a small cranial defect. You put a ferrule in place or a tray. It sits in the tray. It's actually designed to be left in situ. So you don't even have to take it out. You just program the person off. But yes, it would be nice to be able to do a blood test and say, you are a great candidate for neurostimulation, but we can't do that yet. Dr. Duran.
Can you comment a little bit on the development of the algorithms for detection? Because that is clearly crucial to this technology. And in particular, the delay between detection, between the onset of the seizure and detection. And also, did you look at try to predict ahead of time to see if there are seizures coming?
So one question was looking at the time between the event and stimulation, and the other was whether we're looking at seizure prediction. And let me answer the first. I know you've done a lot of very interesting work in the coupling interval. And this is where I think that synchronized stimulation might be helpful as far as identifying the best time to deliver the stimulation as far as the event is concerned. But the issue, or what we've discovered, is that you've got to stimulate as soon as possible. And if you wait for the patient to have a clinical seizure, it's way too late. But clinically, that makes sense, because the clinical seizure is when the seizure is propagated to involve some critical mass of brain. And the question about prediction actually gets to your first question as well. I don't believe in seizure prediction anymore, because we have patients who have now had this device for 8 years. And what we see is a burden of abnormality that's really rather stunning. And so I showed that the typical patient does well with 600 detections and stimulations a day. And we can't wait to see if that would have gone on to be a seizure, because that's too late. But what we do see is that by delivering therapy in this way, that the numbers of detections go down over time. So there is some quieting of the pathologic generator over time. So there is so much abnormality when you're right there and looking at it. I don't know how you could predict which of those events were going to go on and be a clinical seizure anymore. I think you have to not predict that somebody's going to have a seizure on Tuesday. I think you have to modulate that focus that is so ill.
During these studies, what do you do with the patient's baseline anticonvulsants? Do they stay on the anticonvulsants? Do they get tapered off? Obviously, there are different numbers, different amounts. And obviously, one of the gigantic benefits of this technology is eventually to get them off, because that's what improves their cognitive.
So the question was, what do we do with the anti-epileptic drugs? Well, the requirement in the trial was that the medications remain stable during the baseline through the blinded period, and then the physicians could change as medically necessary in the open label. But to no surprise, it was very interesting. 85% of the patients had no changes in their medication during the open label, and that's because if you have one of these patients and they're doing well, you just don't muck around for a long time. I mean, you just leave it alone. But I'll go on and say, and I don't know why we didn't think about this before, but it was just a year ago that I thought, I wonder if the medications influence the likelihood of response to stimulation, because a lot of our medications act at the sodium or the potassium channels. And if you have a medication for seizure, which many of them are, that block high-frequency repetitive firing by blocking sodium channels, gosh, maybe that would make it hard for a neuron to respond to high-frequency repetitive firing. So we took a look at the patients who were on drugs that act only at the synapse, that don't act on channels. And in fact, those patients do better. And then I spoke with one of my cardiology colleagues at Stanford, and he said, well, everybody knows that. And he told me the story about amiodarone, which is a sodium channel blocker. In the first cardiac defibrillator trial, it didn't work. And it almost got abandoned. And then somebody did an analysis, and they found out that it doesn't work when you're taking amiodarone. You can't defibrillate a heart in somebody who's on a sodium channel blocker. But if you're not on that, it works very well. So the next series of trials that have to be done is controlling anti-epileptic drugs based on their mechanism of action. And I believe there's a medication called levetiracetam. The patients who are on levetiracetam do really well. And we'll see somebody doing well, and then all of a sudden they're doing terribly on EEG, ECOG-wise, and we'll find out that the patient was taken off levetiracetam, and then everything gets... So, I mean, this is a way of using medications and stimulation synergistically. And I think that's where we're going to end up. It's not going to be either or. It's going to be adding them together in some powerful way.
It seems like with movement disorder surgery, it kind of started with paladotomy and then went to deep brain stimulation. Do you ever think it would be worth comparing resection to stimulation?
Well, that trial is going on. The question was, is it worthwhile comparing resection to stimulation? That trial has just been started in Germany and Belgium by Christian Elger and Paul Boone. And the trial is taking patients with dominant mesial temporal lobe epilepsy. And these individuals are at some risk for verbal memory impairment and some language impairment after the dominant temporal lobectomy. So they are randomizing these patients to receive stimulation versus resection. And they're looking at seizure frequency, certainly, but their co-primary endpoint is neuropsychological function. They're having a little bit of trouble enrolling patients because, you know, the epilepsy surgery works so very well, but it is progressing. I think there are 15 patients enrolled so far.
What's the expected battery life with the current technology in stimulation settings, and are there concerns about the durability of the scalp for repeated battery revisions?
So the question was the expected longevity and concerns about repeated incisions in the scalp. It is evolving. With our first device, we used a battery from a particular manufacturer, and we were also going up to high charge density. So the end of service was typically 2.5 years. We've switched to a battery from another manufacturer now, and we're going to get 3.5 years. We have the next generation of device that has more efficient integrated circuits, more efficient computational function, and that will take us to 5 years. Once we're approved by FDA, we'll go forward with the 5-year device. And we've also have a prototype for a rechargeable device. But yeah, absolutely. The concern is if you have repeated scalp incisions, you'll ultimately compromise the vascular supply, and you could then end up with erosion and scalp necrosis. And these are young patients who are going to require a number of replacements. Yeah, that's absolutely a concern, and I look forward to the continued improvements in battery technology.
One or two more.
Yeah. Do residual clinical seizures change in duration or expression in these patients?
You know, they do, and what we've seen, we just counted seizures, and that's what we used for our primary efficacy endpoint, and that's, you know, what we'll present and stand by. But if we look at the greatest seizure reduction, it was in generalized tonic-clonic seizures. There was a 90% reduction in those. And then the second greatest was complex partial seizures, and the least reduction was in simple partial seizures, which are the smallest. So a number of patients went from a more severe to a milder, or we'll say that the seizures are shorter. We probably didn't properly capture that, and that's another thing I would change in future studies, is I would figure out a way to capture that data better.
One more question?
Yep. I guess a bigger proportion of the patient had invasive assessment in the trial. And did it change the efficacy of where the actual stimulation is being delivered based on the invasive trial, based on seizure onset zone or any other zone?
Yeah, I believe people heard, but it was a number of patients had invasive monitoring before to localize the seizure focus, and did that change it? I think that knowing where you need to put those leads is the key to this. And if invasive monitoring is necessary to find that out, then it needs to be done. And that probably is essentially every patient with a neocortical onset. The patients who probably will not need invasive monitoring are certainly in every case is the hippocampal onsets, because those patients can often be diagnosed with scalp EEG. I will say one important piece of information about our mesial temporal lobe patients is that more than 2/3 of them had bilateral independent hippocampal onsets. So they weren't candidates for epilepsy surgery, and they had leads in each hippocampus. And we saw seizures sometimes starting left, sometimes starting in the right, sometimes going for a month or 2 months or 3 months on one side, and then switching over to the other side. So to me, as an epileptologist, that makes me think, wow, the monitoring admissions we do to localize people, they're typically, you know, a week, 2 weeks, maybe 3 weeks, but there may be a lot more bilateral patients than we've thought. So some of our investigators are actually thinking this is a good diagnostic localization tool for people with hippocampal seizures, that maybe you do this first and you send people out for 6 months to, first of all, you could see if it works, but maybe even more importantly is to confirm your localization, confirm it's unilateral before you do a resection.
Okay, well,
so,
thank you very much.